Hi, good evening. I'm Dr. Samuel Pauli from Boston IVF, and I'd like to welcome everybody to Facebook Live tonight. I'm really excited to be here, and I'm happy to answer any questions that you have tonight. Just a little bit about myself. I've been a reproductive endocrinologist for about 10 years now, and most of my time has been spent at Boston IVF as a reproductive endocrinologist. Over the last 10 years, I've helped probably close to 3,000 to 4,000 couples achieve their goals of family building, and really excited to be here tonight to answer any questions that you have. A little bit about my background. I grew up in the Midwest. I'm originally from a small town called West Bend, Wisconsin. I did my undergraduate work at the University of Wisconsin-Madison, where I majored in molecular biology. After my undergraduate work, I went to New York City and I did my medical school training at Columbia University College of Physicians and Surgeons in New York City. And after that, I went to Yale New Haven Hospital, where I did a 4-year residency in obstetrics and gynecology. After my residency, I moved to Atlanta, Georgia, and did a 3-year fellowship in reproductive endocrinology and infertility, and that's where I learned my knowledge and skills as a reproductive endocrinologist. And then I moved to Boston after that to go into practice. I am married. I have my wife is also a physician. She's an internal medicine doctor, and we have 2 lovely children. I have 2 girls, ages 13 and 10. And I think a lot of the joy I receive from my family has really pushed me to be a better doctor and to help other couples achieve those same goals of family building as well. And so I'd like to shift gears a little bit tonight, and I'd like to talk a little bit about the first visit. And I think there's sometimes couples will have a difficulty scheduling that first appointment and knowing what to expect at that first appointment. And so what I'd like to do is kind of demystify kind of the first initial visit. And so I'd like to talk a little bit about what happens at the first visit. And so during the first visit, usually it's just a conversation. We'll sit down, we will talk a little bit about your goals and your journey leading up until that first appointment. And usually we will take a detailed medical history. So we'll go over both your and your partner's medical history. And then after that, we'll talk about some of the initial testing that we do to assess one's fertility. And usually I break that down into kind of 5 key areas. So the first thing that we look at is ovarian reserve. And basically, ovarian reserve is basically just a way of looking at the biological clock. And the way that we assess that is we have the woman call when she gets her period. She comes in on the 3rd day of her period, and we do an ultrasound and some blood work. That initial ultrasound is basically just looking at how many eggs we can see in the ovary. And we can count these small, what are called antral follicles, that are eggs that are just starting to develop in the ovaries. And so we do an egg count, and then we will also run some hormone tests. And those hormone tests are usually some hormones called FSH, LH, estrogen, and AMH. And really from a combination of looking at these lab values as well as the ultrasound, we can get a good assessment of how many eggs are there, how responsive or receptive those eggs may be to medications, and really a good assessment of kind of where your biological clock is. The second thing that we look at is usually a semen analysis if you have a male partner, or if you don't have a male partner, we will talk about use of donor sperm. And when we do a semen analysis, basically we are looking at several parameters that are predictive of the sperm's ability to fertilize the eggs. And so usually we will look at the volume of sperm, the concentration, how many sperm are moving, how fast they're moving, and the shape of the sperm to get a good assessment of the sperm's potential. The third thing that we look at is the fallopian tubes. And to assess the fallopian tubes, we do this fancy test called a hysterosalpingogram. Some people call it an HSG, some people call it a dye test. But basically what it is we have you come in after your period has ended, somewhere between days 5 and 12 of your cycle. And basically, we place a speculum, we put a little catheter inside the cervix, and we put some dye through that catheter. And if the fallopian tubes are open, what we can see is we can see the dye kind of flow out the ends of the fallopian tubes. And we can see that on fluoroscopy. It's kind of a fancy x-ray, essentially. And we do that for two reasons. One is we want to make sure at least one of the fallopian tubes, and hopefully both of them, are open. And second, there's also some benefit of just doing the HSG test, in that when you flush out the fallopian tubes, sometimes you'll make a woman a little bit more fertile in the following couple of cycles, just from kind of that mechanical kind of flushing out of the fallopian tubes. And so that's how we assess the fallopian tubes. Sometimes you may have heard some stories about the hysterosalpingogram or the HSG test. It sometimes can be a little bit uncomfortable. I do usually recommend that you take some Motrin or Advil on the day of the test, and that will help minimize any cramping that occurs during that test. The fourth thing that we do is we look at the uterus, which carries the pregnancy. And we can look at the uterus two ways. Usually we'll look at it with just a general ultrasound when we're looking at the eggs, and we can look for things like fibroids and other structural issues that sometimes occur in the uterus. And then also, when we do the hysterosalpingogram, the dye also goes through the uterus, and so that also can tell us a little bit about the shape of the uterus. So we get some information from both of those tests about your uterus. And then lastly, I kind of lump everything else into kind of a broad bucket that's called the prenatal labs and genetic testing. And so there are some labs that we do for anybody that wants to get pregnant that are important. We check your thyroid hormone, we check your blood counts and your blood type. We check for some immunities to some viruses like rubella and varicella. And then we also will offer all couples sometimes some genetic testing as well. Often we'll screen for both what are called X-linked disorders as well as recessive disorders as well. And so that's kind of the basic testing that I break down to couples that happens at that initial visit. Also, usually at the first visit, we'll talk just briefly about what some of the options are for treatment as well. Usually those fall into two general categories, usually either medications and inseminations, which we may get into later on tonight, as well as IVF as another option. And IVF can either be done with or without genetic testing of embryos, which again we can get into more depth later on tonight. But that's really that first visit, kind of in a nutshell. And we usually give a couple kind of a written plan and kind of what their next steps are going to be. And then usually they will go off, do those testing, and then we will meet back for a follow-up visit. And at that follow-up visit, we sit down and we review all the tests that we did. And then we look and see what issues we may have identified. And then depending on what those issues are, then we make a customized plan to kind of help the couple achieve their dreams of pregnancy. And so that's kind of the first visit in a nutshell. And so with that, I'm going to go to some of the questions that we've had. And so I apologize in advance if I don't get to everybody's questions, but we'll try and do as many of them as we can. I see a bunch of my former patients are on here already, and really excited that some of them are back and are able to join us today. Good to see you, Claudia. And I have a patient that I saw today that actually is now on the feed as well. So that's great to hear and welcome, and looking forward to seeing more of you. There's a question here about what are the first steps to getting donated sperm, and so that's a really good question. And so we see sometimes lesbian couples who are often needing donor sperm to achieve, as well as we sometimes see a single female who are searching to get pregnant without a male partner. And sometimes we see couples where the male may have no sperm. And so all of these individuals need donor sperm. And usually the first steps to acquiring donor sperm are first essentially is to do kind of the basic testing, which we talked a little about earlier, to kind of assess kind of any of the fertility needs. But there are a couple of tests that are necessary for choosing donor sperm. And that is you need to know your blood type because it's important to know your blood type, because if you have a negative blood type, it's advantageous to pick a sperm donor that also has a negative blood type. The other thing we look at is do some testing for something called CMV, which stands for cytomegalovirus. CMV is a common virus, kind of if you get it, it causes like the common cold. And if you've had CMV before, you have antibodies for CMV, and you shouldn't get CMV again. And so if you've had CMV in the past, you can pick a sperm donor that is CMV positive or CMV negative. If you are, however, CMV negative, it is recommended that you pick a donor that is also CMV negative, just so that there would be no possibility of you getting CMV from the donor. Even though the donor shouldn't have active CMV when the donor donates, it is still recommended that you pick a CMV negative donor. So usually those two key components are necessary when selecting a donor. And then, the nice thing about selecting a donor is there are lots of different options, and we work with lots of different sperm banks. And so it's, we would kind of guide you through that process of how to select a donor. Looking here. Hi, Tara. How are you? Victoria, hope your twins are doing well. Lots of former patients here. Really good to see everybody tonight. There's a question here about how hard is it for a same-sex couple to go through the process to try and have twins with IVF, and I'll just make a slight comment about that. There are lots of different ways for same-sex couples to conceive. Sometimes that's through donor sperm inseminations, and sometimes it is through IVF. Sometimes that's if donor sperm inseminations don't work, and sometimes that's if a couple decides to go straight to using IVF. I'd say in general with fertility treatment, we try not purposely to make twins, and the reason for that is that twins are associated with a higher risk of medical complications, and so usually our goal is a happy, healthy singleton pregnancy. Now, sometimes through fertility treatments, twins do happen, and we have lots of couples that are very happy with their twin pregnancies. But because there are increased risk of twins both to the babies as well as to mothers, we try not to purposely make a twin pregnancy. Now, what are some of those risks? Well, we know for moms that have twins, there's a higher risk of gestational diabetes. There's a higher risk of blood pressure issues in pregnancy. There's a higher need for bed rest. There's a higher risk of needing a C-section as well, and a more difficult recovery. For babies, if they're born early, and often when there is a twin pregnancy, the babies can be born premature, there's a higher risk of the lungs, stomach, and brain not being fully developed. And so because of those increased risk of complications, we really try and minimize essentially the risk of twins. But like I said, sometimes it does happen. So I'm looking here. Somebody's asking a question about having a high FSH and a low AMH, and I would like to say is that a lot of times we do testing for ovarian reserve, and we look at what that ovarian reserve is. Sometimes our ovarian reserve comes back very well, and sometimes it comes back low. And if the ovarian reserve does come back low, there are many different options that one can consider. There's no absolute value, no FSH level, no AMH level where we would say somebody cannot have a pregnancy. Now, having a low AMH level or a high FSH level does often mean that it's more difficult to conceive. And if we are doing IVF stimulation or even Clomid and insemination, often it is more difficult to stimulate the ovaries. But there is no absolute cutoffs in terms of that. Often your doctor will customize your treatment plan based on what those levels are. If the hormone levels suggest there's low ovarian function, we're going to be much more aggressive in terms of the protocol that we use in order to help stimulate the ovaries. And it's a great question and something you can definitely ask your doctor about. Next question says, when and if would you suggest doing an ERA? So an ERA is kind of a special test that we sometimes offer. It stands for endometrial receptivity assay. And an endometrial receptivity assay basically assesses for implantation and the implantation window. So that's essentially when the uterus is ready to accept an embryo. And it depends, the time in which the uterus is ready to accept the embryo depends on the timing of the transfer as well. And so usually the patient that I'm going to recommend that has an ERA or a special test to look at when this window of implantation is usually somebody who has failed multiple IVF cycles where we've taken a very nice looking embryo or embryos and we've implanted them into the uterus and they failed to get pregnant. Usually that's somebody that's failed probably 2 or 3 transfers of embryos that have not had genetic testing, or has failed 1 or 2 transfers where they've transferred a known screened what's called euploid, or an embryo that's undergone genetic testing, and that type of a cycle has failed. So those would be the patients that I would recommend an ERA for. I don't think that all patients need an ERA, which is essentially is where you do a mock cycle where you prepare the uterus for a transfer, and then on the day of when you would do the transfer, you do what's called an endometrial biopsy. You take a sampling of a few cells from inside the uterus, send it off to a genetics lab who amplifies the DNA. They can check and see which genes are turned on and turned off to see if kind of the right signature profile for implantation is there. And often when they do this test, they can tell us if we need to shift the timing of the transfer either earlier or later, essentially to look into that. And looking at some of the other questions here. One question says, if you have a miscarriage, is it still recommended to test to see if the tubes are open? A lot of times I still do recommend it, other than just telling if the tubes are open from an HSG test. You can also tell a little bit about what's called the caliber or the diameter of the fallopian tubes. And so one of the other things we can kind of see if there's ever been any infectious process that's going on with the fallopian tubes, that's something called a hydrosalpinx, where the fallopian tube is dilated. There's some thought that sometimes dilated tubes sometimes may either prevent implantation or could potentially increase risk of miscarriage as well. So it's not a bad idea. Also, sometimes just knowing if one or both the fallopian tubes open, I think is beneficial to know, is this something that we trying to get pregnant on our own? Would we want to consider any type of fertility treatment to kind of speed up the process? And so I think sometimes just having that complete evaluation. Sometimes couples say, well, should I only just test the sperm first or the egg first or whatever? And I kind of like to take the approach of kind of testing everything. So that way we don't just find and identify one problem and then 6 months later we find something else that we wish we had known about sooner. So I like to do kind of more comprehensive testing up front. So kind of get the full picture, and then we can really focus on kind of what the issues are. So I don't think it's necessarily a bad idea, although, if you are getting pregnant and you're miscarrying, you have to have at least one open fallopian tube. And so, maybe a little bit less value in that situation, but I still think there's some value in doing the test. One question is about if you have frozen embryos, how soon should you contact your doctor to kind of know, when you should come back and start planning to do a frozen embryo transfer. And so a frozen embryo transfer is either done in usually one of 2 circumstances. It's either where somebody has done IVF and they transferred embryos and it didn't work, and there happened to be extra embryos that were frozen. And so sometimes it's done when an IVF cycle doesn't work and there are extra embryos that then you can use for kind of a second chance or a bonus cycle to try and allow that same batch of eggs or embryos to work. And often what happens is if you have a negative pregnancy test and you have extra embryos, you'll meet back very quickly with your doctor, you'll talk about your frozen embryos, and then you'll have a plan to do a frozen embryo transfer. Usually there's 1 rest month in between finishing an IVF cycle and then starting a frozen embryo transfer. The other situation, and one of my favorite situations, is where you have a couple who has done treatment, let's say with IVF. They're successful, they have their first pregnancy and delivery, and you also have these extra bonus embryos. And when that happens, they will come back a year or 2. Sometimes they bring the first baby back into the office and we can see them. And they have these extra embryos and they're going to prepare for their second pregnancy. And so usually when we are planning a second pregnancy, we'll check just a few things. So we kind of went over all the stuff that we tested initially at that initial consult. When somebody's coming back and they have frozen embryos already, it's a very small number of tests that we have to do. Usually it boils down to checking their blood counts to make sure they're not anemic, checking their thyroid hormone to make sure it's in balance. Sometimes we'll redo their day 3 labs as well, just to kind of get an assessment of kind of where their fertility is at the moment, as well as the ultrasound just to make sure the ovaries and uterus look normal. And then we also will do usually a separate test that looks at the inside of the uterus to make sure that it's ready for implantation. So we don't usually repeat that dye test again. We don't really need to check the fallopian tubes for doing a frozen embryo transfer, but usually we will either do one of 2 tests. One is called a sonohystogram or a saline infusion sonogram. It's where we put a little catheter inside the cervix, put some water in, and we check to make sure there's no polyps, fibroids, scar tissue, anything that would block the implantation of one of these frozen embryos. Or we do something called an office hysteroscopy, which is a quick look inside the uterus with a camera. Again, can tell us if there's any problems that would block implantation, a small polyp or fibroid, something that we would want to clear up before thawing and transferring the embryos. And so usually that can all be done within a month. And so I usually say it's probably best to make the appointment with your doctor about 3 or 4 months ahead of time. That way, if there's a little bit of a wait to see your doctor, you get in for that appointment, you go over the tests, you would call with your next period. They would do those few tests, usually a blood work and ultrasound maybe on day 3, one of those tests of the uterus somewhere between days 5 and 12 of your cycle after your period has ended. And then usually the cycle after that, you could proceed with the frozen embryo transfer. So it's about, I would say, give yourself a kind of a lead time of about at least 3 months, 4 months, just to be extra safe in terms of that. So, hi Karen, congratulations. Good to see you, Kristen. So this is an interesting question. It says, waiting for PGS results. Are top grade embryos more likely to be normal? And this is a really interesting question. And so for those that don't know what PGT-A is, so PGT-A or PGS, PGS stands for pre-implantation genetic screening, but kind of the newer name for it is called PGT-A, which stands for pre-implantation genetic testing for aneuploidy. That's where we do IVF, and we grow the embryos out to days 5, 6, and 7 of development. We do a biopsy of the embryos, and so each embryo has 2 parts. It has an inner part that becomes the embryo, or becomes the baby, and an outer part that becomes the placenta. And what we do is we do a biopsy of the outer part of the embryo, the part that becomes the placenta. And we take usually 3 to 5 cells from that area of the embryo, and then we freeze the embryos. And we send those few cells that we biopsied off to a genetics lab who amplifies the DNA, and they test the embryo to see if it's normal or not. Now, what do I mean by if it's normal or not? It's basically each embryo should have 23 pairs of chromosomes. And they're making sure that all those chromosomes are there, that there's no extra chromosomes, there's no missing chromosomes, partial deletions, duplications, etc. And if the embryo is normal, that is an embryo that is more likely to implant when you transfer it to the uterus. It's less likely to miscarry, and it's less likely to have a birth defect, let's say, due to a chromosomal issue like, let's say, Down syndrome or Turner syndrome or Klinefelter syndrome, trisomy 13, 18, other essential chromosomes abnormalities that can cause problems with babies. And so that's the PGS testing. And so when we freeze embryos, we also give them what's called a grade. And just a quick background on what embryo grading is. So embryo grading is where the embryo essentially gets 3 scores. It gets a number grade, which is from 1 to 6, and that is related to the size of the embryo. Most embryos are frozen when they're between a stage 3 and a 6. That means they've reached the blastocyst stage, the expanded blastocyst stage, or it is either a hatching or a hatched blastocyst. So it's one of the larger blastocysts. And then it gets 2 letter grades, and those are either an A, B, or a C. The first letter grade refers to the inner part of the embryo. That's the part that becomes the baby. Kind of a B is an average score. That's what most of our embryos are graded at. An A is an above average score. Those are the really nice ones. A C is a below average score. That means there is not so many cells in that area, not as great of an embryo. And then the second letter grade, again, gets an A, B, or C score. That refers to what's called the trophectoderm. That's the outer part of the embryo that becomes the placenta. And so that also gets the A, B, or C grade as well. Now, when you look at the grades of the embryos don't necessarily correlate with whether the embryo is normal. And so sometimes your best looking embryo, you could have a 4AA embryo, but that embryo may have multiple chromosomal abnormalities, or it may have just one chromosomal abnormality, but the best graded embryo doesn't necessarily mean that that's the one that's most likely to be normal. And a matter of fact, there's several interesting studies that are out there that show if you just transfer based on the grade of the embryo, and then you do the genetic testing of the embryos, and you look at, would have you transferred the same embryo whether you had or hadn't done the genetic testing, up to a third of the time, the embryo that you thought was the best ends up being an abnormal embryo. And you actually would have picked one of the lower graded embryos because that was actually one of the normal embryos. And an abnormally graded embryo has a very, very low likelihood that it would ever result in a pregnancy, where the embryo that is normal, that one has a very high chance of implantation and forming a pregnancy. So that's why, I kind of think about it as the genetic testing or doing PGT-A of embryos is really just a selection tool. If you have a group of embryos, let's say 4 or 5 embryos, and you want to know which one has the best chance of implanting, you can do one of two things. You can either just grade them, and there's a little bit of truth that the higher the grade of the embryo, the higher the chance of pregnancy. And that's why we grade them, is that, all things being equal, we would transfer the embryo with the highest score. But then when you add the genetic testing on top of that, what you find is that's even more predictive in terms of chance of success. And so if we know an embryo is normal, we would then transfer the normal embryos first. And again, if we have multiple embryos that have that have normal genetic testing, we would transfer the highest graded embryo that had normal chromosomes. So hope that helps with that question. Great question. Hi, Melanie. It's 5 years old. Wow, time goes by quickly. It says complications of carrying a pregnancy with PCOS. And so, PCOS stands for polycystic ovarian syndrome, very common condition. Probably at least 10% or more of the patients that we see have polycystic ovarian syndrome. And it often is very difficult to get pregnant with polycystic ovarian syndrome because one of the features of polycystic ovarian syndrome is that ovulation is irregular, and women don't always ovulate or release eggs. And so it can sometimes be a struggle to get pregnant, but we definitely have a lot of tools to help women with PCOS ovulate and to get pregnant. And some of them will get pregnant with medications such as letrozole and inseminations. Some of them require IVF to conceive. In terms of their risk of complications, once they are pregnant, their pregnancies are fairly normal. They don't tend to have a lot of complications compared to a regular to any other patient that conceives. I'd say the one exception is one of the other hallmarks of polycystic ovarian syndrome is sometimes insulin resistance, and so there is a little higher risk of gestational diabetes in mothers that have polycystic ovarian syndrome. So I think that's probably the biggest risk. There are a couple of studies, and this kind of goes back and forth, whether PCOS increases the risk of miscarriage or not. Some studies suggest that, some studies don't. So there may be a slightly higher risk of miscarriage. But in general, most of their pregnancies are going to do quite well. Another question says, if my donor has a negative blood, does it matter what my blood type is? No, it doesn't. So if you, the person receiving donor sperm, has a negative blood type, then the donor should be negative to reduce something called RH sensitization. But if you are RH positive, so meaning you have a positive blood type, it doesn't matter whether your donor is positive or negative. So very good question. It says, at what age do eggs decline in their quality? And so, I would say, your egg quality is at its peak in your 20s, essentially. There are very subtle declines that happen in egg quality starting in average. Eggs can decline at any particular age, but in general, we start to see subtle declines in egg quality around age 32. And that decline really accelerates more in the mid-30s. So around age 36, 37, 38, 39, that's when we start to see things kind of decline at even a greater rate. But you can sometimes see even subtle declines even earlier. And sometimes we see even women in their 20s who have already had decline in ovarian function. And similar, we sometimes see women that are in their early 40s that have, great ovarian function. So it's not everybody's the same, and that's why we really have to test, and we have to customize and individualize treatment for every person. Hi, Samantha. Congratulations as well. It says, I'm doing IVF. Does my husband have to do a sperm analysis before? I will be 38, just found out both tubes are blocked from the HSG test. So definitely, anybody that's doing IVF, I would recommend that their partner has a semen analysis, and you'd really want to assess the sperm. And part of the reason for assessing the sperm is when we do IVF, there are two ways of fertilizing eggs. There's something called conventional or natural insemination. That's essentially where you have the egg in the dish, and the gentleman has a lot of sperm, and essentially you add 50,000 sperm per each egg, and kind of use, and what I say is kind of the strongest sperm of that 50,000 sperm that we add to that egg will then fertilize that egg. And so it's kind of survival of the fittest. Whoever gets there first and gets inside the egg will fertilize the egg. The other thing we sometimes see is sometimes men will have sperm, but they have very, very small quantities of sperm. And in that situation, you may not have a lot of sperm to kind of surround the egg. And what's interesting is if you just add a few sperm, 3 or 4 sperm per an egg, and you put them in a petri dish, often you will not get any fertilization at all. So you need kind of a lot of sperm. You need that 50,000 sperm because the sperm are a little bit confused. They're swimming all over the place. They're maybe not as goal-directed as we'd like them to be, so that they swim right into the egg and fertilize it. So you have to add a lot so that you kind of get one that's on track and gets in and fertilizes the egg. So if a guy only has a few sperm and you don't have enough to kind of do that natural insemination, we do something called ICSI. ICSI stands for intracytoplasmic sperm injection. And essentially that's where we take an individual sperm and we inject it directly into the egg. And we do this usually when there's severe male factor infertility, and we also do it in a couple of other instances as well, where you want to purposely add one egg and one sperm together. And so having that semen analysis ahead of time, even if you know your infertility is from blocked tubes or some other reason, you always want to evaluate the sperm as well, so that you know how best to fertilize the eggs. Next question is somebody that's doing donor egg and says, my donor is 22, would you suggest one embryo transfer? Absolutely. So the chance of pregnancy, and this is really key, is so the chance of pregnancy is related to the age of the egg. And so even if you may be a younger, older patient, because I don't consider 40 to be old, is that, if your donor is younger, the number of embryos you transfer is based on the age of the donor. And usually when somebody's using donor egg, we almost always universally recommend a single embryo transfer because the egg quality is quite high and the chance of pregnancy is quite good. We had talked a little bit earlier about risk of twins, and if we transfer more than one embryo in somebody doing donor egg, we have a very high risk of twins, and then an increased risk of complications to the recipient that is receiving those donor eggs. So I would definitely recommend a single embryo transfer in that case. Another that kind of brings up another point that I think is interesting, is that, as we talked earlier about, sometimes when somebody does IVF, they have extra embryos, and often we will recommend freezing those extra embryos. And part of the reason for that is, let's say you do IVF and you're 34 years old, which is a great age to do IVF. Chance of success is very high, probably 45 to 50% chance that you'll get pregnant on your first cycle of IVF. And so let's say you get pregnant and you have these extra embryos. Well, now let's say you want to have your next baby when you're 38. The success rates of doing IVF at 38, if you were to start back over and do the IVF again, are probably around 35%. So your chance of pregnancy is not as high as it was when you were 34 and you did IVF. Now, the cool thing is, if you froze embryos when you were 34 and you have those embryos and they've been frozen for a few years, and now you come back to use them when you're 38, the embryos don't age as you age. And so they're still 34-year-old embryos, and your chance of pregnancy is not that of somebody who's 38 getting pregnant, it's that of somebody 34 getting pregnant. And it even gets better, because your risk of miscarriage, again, is not related to somebody that's 38, it's related to somebody that's 34, because that's how old the embryos are, or the age at which you created the embryos. Same thing with the risk of birth defects. The risk of a birth defect is that of a 34-year-old, not of a 38-year-old. Same thing when you're doing donor egg. If your donor is 22 years old, your risk of miscarriage and your risk of birth defects is that of a 22-year-old, not of a 40-year-old if you're 40 years old and doing donor egg. So that's something that's kind of cool. Hi, Dawn. Great to see you, too. This is a really good question. What are the reasons an embryo that has been PGS tested, so we've checked the chromosomes, may still not implant? And so it's a really good question. And so, and to take that a step back, so when we transfer an embryo that's been screened, a PGS tested embryo or PGT-A tested embryo, I usually tell patients the chance of pregnancy is around 60 to 65% chance that embryo will implant. And why the difference, 60, 65%? Some of that depends a little bit on the grade of the embryo. The better the grade, it's maybe slightly higher, et cetera. A little bit depends on the age of the patient, and that can sometimes affect chance of implantation as well, even with a PGT-A tested embryo. But PGT-A is only one part of the embryo. It's only telling us about the genetics of the embryo. It doesn't tell us about everything else related to the embryo. And usually when an embryo transfer doesn't work, and this can be either in a PGT-A tested embryo, or it can even just be in a regular IVF cycle without PGT-A, I usually talk about the 3 reasons why embryos don't fail to implant. So one is it could be a problem with the embryo. In the case of PGT-A, it's not because it was necessarily a genetic problem with the embryo, because that was tested. It was checked to make sure those 23 pairs of chromosomes were there. But sometimes there can be other problems with embryos, non-genetic problems with embryos. It could be a problem with the cellular machinery, something that that essentially didn't allow that embryo to kind of take off. Or when that embryo was thawed and then put back in place, the embryo just kind of never got restarted again in terms of its development. Something else was off with the embryo other than the genetics of the embryo. So it could still be an embryo issue. Second thing, it could be a implantation issue. So had nothing to do with the embryo. The embryo was perfect and good and ready, but it could be a problem with implantation. That could be a structural problem with the uterus, and that's why a lot of times before we'll do a frozen embryo transfer, I usually recommend that there's been some evaluation of your uterus, whether that be a saline infusion sonogram, that saltwater ultrasound we talked about earlier, a camera test, that diagnostic hysteroscopy, or at a very, very minimum, the hysterosalpingogram within the last year that also would have looked a little bit at the uterus as well. But all of these things look to make sure that the cavity or the inside of the uterus is ready for implantation. The other thing it could be receptivity, and that's why we talked about if somebody fails multiple IVF cycles or is not getting pregnant when screened embryos come in, that may be a situation where that endometrial receptivity assay may be beneficial. Maybe it's an issue with the timing. When we do a frozen embryo transfer, we make sure that timing is very precise in terms of when we start progesterone, if it's an estrogen progesterone cycle, or if we're doing a natural cycle or a modified natural cycle with letrozole and an HCG trigger, we're going to want to make sure that that timing is good. But there are some women that require a little bit of different timing, and that's why where sometimes that ERA test can kind of come into play. And then the third reason could be a technical reason. We are very, very careful when we transfer an embryo. So when we transfer an embryo, we do it under ultrasound guidance. So we put an ultrasound on your tummy. We do a practice run, usually with an empty catheter, making sure we can line up the embryo, put it exactly where we want to, exactly, usually in the upper middle portion of the uterus. And then once we deliver the embryo to the uterus, we take the catheter out and we have our embryologist take it back to the lab, and we have them look at it under the microscope and make sure that the embryo was actually delivered. Embryos are sticky. They want to attach. They want to attach in the uterus, but occasionally they misbehave and they actually stay attached to the catheter. And so about 1 in 100 transfers, you will think that you put the embryo in and you actually take the catheter back to the lab, you look at it under the microscope, and you find out the embryo never came out of the catheter. It's stuck to the side. And when that happens, we repeat the transfer again and we check again, and usually it gets transferred the second time around. Now, interesting, when they've looked at this, the pregnancy rates are no different whether the embryo goes in the first time we put it in, or let's say it's stuck to the side of the catheter and we have to do it all over again. The chance of pregnancy is exactly the same, but we want to make sure it actually got inside because it can implant if it doesn't actually get inside. So again, just to summarize, reasons why a cycle may not be successful: a problem with the embryo. In the case of genetically tested embryo, maybe an embryo that wasn't that had some other problem other than the genetics. Could be a problem with implantation, or it could have been a technical problem with the transfer itself as well. So let's take a look here. The next question that I'm going to answer talks about how many IUIs do you do before you go to IVF, and it's a great question. And there's no right or wrong answer to this, really. Sometimes there are insurance requirements that say we have to do X number of insemination cycles prior to IVF. There are several insurance carriers, particularly in Massachusetts, where I see majority of my patients, where you have to do 3 insemination cycles before proceeding to IVF. Other times, insurance don't have a restriction in terms of the number of inseminations. Some couples bypass inseminations completely and go straight to IVF. Some couples are hesitant to do IVF, and in that situation, we may try more than 3 cycles. Sometimes we will do 6 cycles, or or we will do some cycles with medications and intercourse at home. And if that doesn't work, then we may add insemination. So it's really customizing it based on the couple's goals, and sometimes there are some insurance restrictions, but there's no right or wrong answer. I would say for most patients, though, we usually recommend 3 cycles and then moving to IVF. That's kind of our standard guidance, but it definitely can be customized based on one's individual goals. It says, how long after birth can you transfer another embryo? So really good question as well. And I see a lot of returning patients who have embryos frozen and want to know when they can come back, and they're usually in a rush to have the next one. And a lot of times people want to space their pregnancies appropriately. And so there's a couple different answers to this question. So if you ask the American Academy of Pediatrics, they recommend that you wait a year and a half in between pregnancies. That's their standard recommendation for what's called the interpregnancy interval, the interval between having a baby and when you should get pregnant again. Now, I can tell you a lot of my patients don't want to wait a year and a half in between pregnancies, particularly if they started their family building later in life, where they already feel that they're a little bit behind and they're concerned about their ovarian reserve, and we may not have that much time to wait because of concerns that if we wait that long, they may miss their opportunity to get pregnant again. And so I would say most couples will wait about a year, and that gives some time for healing from the baby in terms of the uterus. It also gives some time to adjust to the new baby that's at home. We can, kind of the earliest that we will see a couple back to do another transfer or to start treatment again, whether that be inseminations or IVF or whatever treatment it is that we're doing, would be 6 months. That's kind of the absolute kind of soonest that we could see somebody back to start treatment. And part of that, again, is just that the uterus requires a little bit of time to heal after that delivery. It has to go kind of shrink back. You can imagine the uterus has expanded multiple times what its normal size is. It has to go back to its normal size. The cycles need to resume. Usually we recommend that a woman has finished breastfeeding before starting another cycle. So in order to kind of accommodate for all of those special needs, usually we recommend at a very, very minimum 6 months, but usually we encourage more 9 to 12 months before proceeding with the next pregnancy. It says, when would you recommend IUI rather than IVF? And so again, there are lots of different reasons why we may choose one option over another. And I would say a lot of couples qualify to do inseminations or even to do medications and intercourse at home. There are a couple of circumstances where we have to do IVF, though. If somebody has 2 blocked fallopian tubes, there's really no way of getting pregnant other than IVF. The other situation we sometimes encounter if the male partner has really, really low sperm counts and there's just not enough sperm to get pregnant either naturally or with inseminations, that's another situation where the only answer really is IVF. Pretty much all other situations, depending on the couple's goals and wishes, probably are candidates for either medications and inseminations or medications and intercourse at home. And so there's really not a lot of absolutes there. It just depends on what your goals are. The other thing is if we find a particular genetic condition that runs in a family, let's say there is a couple where they both carry the gene for cystic fibrosis, let's say. That's another situation where we would probably not want to do inseminations because they would be at risk of having an affected child, where we would skip inseminations and go straight to IVF in order to address that potential genetic concern through something called PGT-A. It's a special type of genetic testing where we can screen the embryos to look for an individual disease that a couple may know that runs in their family. And I do a lot of those cases, and they're very rewarding because we can help future generations from undergoing suffering that may have already afflicted a family previously. Let's see. Next question says, does weight impact the success with IUI and IVF? And I'd say that's an area, a little bit of controversy. I would say there are some studies that show that weight does affect success rates, both of inseminations and IVF, and then there are other studies that show it doesn't. And so really the literature is not crystal clear in terms of weight and success rates. And I think it's kind of one of those things we all know. Women that are either heavier or thinner who have gone on and conceived. Same thing even with smoking. We know there are women that smoke that conceive, even though we know that smoking lowers chance of pregnancy by 30 to 50%. And it's actually one of the, if somebody is smoking, it's one of the things that they can do that will is stopping smoking is one of the things that will dramatically, much more than any medication I can give, will increase their chances of success just by stopping smoking. There is maybe some effect of weight in infertility, and we definitely know that being heavier does increase the risk of complications in the pregnancy. So definitely I'd encourage, if you are on the heavier side, some modest weight loss can sometimes reduce your risk of complications like gestational diabetes, preterm labor, et cetera, in pregnancy. So there are some benefits from that, but there are definitely, women can get pregnant both essentially at any weight. Next question asks about how does your thyroid function affect your ability to conceive? And so we, as I mentioned earlier in the talk, we do check thyroid hormone as one of the hormones that we check as part of the basic workup. And I'd say the thyroid is probably more important for ability to carry the pregnancy and not to miscarry than it is for actually getting pregnant. Now, if somebody is profoundly hypothyroid or hyperthyroid, they may have what's called ovulatory dysfunction. They may not get their periods, or they may get their periods too quickly. And so that can sometimes affect their fertility. But usually that has to be an extreme case. It's somebody that has really, really, really bad hypothyroidism or really, really bad hyperthyroidism, where it's going to interfere with their menstrual cycles and not allow them to get pregnant. The thing that I'm usually more concerned about is if somebody's thyroid function is off, and sometimes it doesn't even have to be off that much, is that sometimes having low thyroid function can increase the risk of miscarriage. And so that's usually why we're checking what's called the TSH, the thyroid stimulating hormone, to see if that number is imbalanced. And if the number is off, often we will supplement with some very small doses of what's called levothyroxine, thyroid hormone, to basically, not so much in terms of helping you get pregnant, but it's more so that when you are pregnant, your risk of miscarriage is lower. So a lot of times thyroid treatment is for miscarriage prevention, not so much in terms of getting pregnant, although in the extremes, it can also interfere with the ability to get pregnant. Next question, how much impact does a high FSH level have on IUI and fertility? So a high FSH level usually means, and essentially, let's take a step back. So FSH stands for follicle stimulating hormone. It's the hormone your brain makes that tells you to make the egg. And normally what should happen is the brain should send a small amount of that signal to the ovary, and the ovary should respond and make an egg in that month. And if the ovaries are not working very well, and often that's because there is not very many eggs there, what happens is the brain has to send a really, really high amount of the FSH in order to get that ovary to work. It's kind of like the ovary is not working well, and so it requires a lot of signal from the brain in order to get it to respond. And so that's what that high FSH is indicating, is that the ovary is not responding well to the signals, and so a lot of that FSH hormone is going to basically produce that egg that month. And so the FSH is predictive a little bit in terms of chance of pregnancy. It's also predictive in terms of response to medications. Like I said earlier, there's no level of FSH or AMH that says whether somebody can or cannot get pregnant, but it likely will affect what types of medications your doctor use, how strong of medications they use, what type of treatments they recommend. And so that's why I think the FSH is important. But can somebody do insemination treatments with a high FSH? Absolutely. And definitely women can get pregnant with a high FSH with insemination treatments and with IVF treatments. Next question is, are ovulation tests home strips accurate for tracking a cycle? And so they can be very useful. And so for those of you that don't know a lot about ovulation predictor kits, essentially these are kits that you can buy at the drugstore, and usually you'll start them before you'd anticipate that you'd ovulate. So if a woman has a 28-day menstrual cycle, usually you're ovulating somewhere between days 12 to 16 in general. And so usually you want to start the ovulation kits a few days before you'd anticipate that you'd ovulate. So a lot of times we say to start them on day 10. That's before we would anticipate an ovulation occurring. And basically each morning, or you look at the package insert, some of them are a little different, but usually it's, every morning you get up, you take a sample of urine, and it's almost like a pregnancy test, or some of them are just little strips that you dip. And basically you check to see if there is a color change and if the ovulation test is positive. And when an ovulation test strip turns positive, it usually means that you're just about ready to ovulate. Because what it's looking for is a hormone called LH. That stands for luteinizing hormone. And the luteinizing hormone usually goes up about 24 hours before you ovulate, 24 to 36 hours before you ovulate. So it's kind of a warning sign. So if you detect that change in that kit, it usually means you're just about ready to ovulate. And so that's how couples sometimes will predict when they're going to have intercourse. And so if that kit turns positive, usually you're going to start intercourse the day that the kit turns positive and for the next couple days afterwards. In terms of timing of intercourse can be every day or every other day. The studies don't show a huge difference in pregnancy rates depending on whether you're having intercourse every day or every other day. But the ovulation kits are a good way of kind of predicting kind of when your peak fertility is and kind of when you should be most active trying to conceive. Now, ovulation predictor kits don't work well for everybody. So there are some groups of women where they don't work well for it. So if your cycles are very irregular, sometimes it's very difficult to determine when you're ovulating just because the ovulation is so variable. It's not kind of in that kind of nice, predictable, day 12 to 16 day window, and really just kind of, it's kind of just using those ovulation kits to kind of just narrow it down a little bit more. If your cycles are anywhere from, let's say, 26 to 45 days, the window of ovulation is very large there, and so sometimes it's very difficult to do those ovulation kits. There are also some women that don't ovulate who the kits never turn positive. Women with polycystic ovarian syndrome, we talked a little bit about PCOS earlier, they often have a hard time detecting ovulation with ovulation kits because they naturally have a high LH level, so oftentimes they will get false reads or the tests don't turn positive at all because of not ovulating. Sometimes there can be women that have something called hypothalamic dysfunction, where they also don't ovulate and the kits don't work well for them either. And so, but I would say for most women, if you are able to detect that surge, they can be very accurate and highly reliable, particularly if somebody has fairly regular cycle and it's about near the time that you would expect it to be. Can be a very useful adjunct for fertility treatment or knowing when to time intercourse. Let's see here. If it's somebody, there's a question here about if they have multiple positive ovulations. So everybody's what's called LH surge. So like we talked about, your LH hormone goes up right before you ovulate. So some women, that LH surge is very abrupt, and so it's a kind of a quick peak. And so some people will only get the LH surge on one particular day that it'll be positive. Other women have a much more gradual LH surge, and so it'll go up a little slower and it'll stay around a little bit longer. And so they may test positive for 2 or 3 days in a row. And usually it's at the start of when you detect the surge is when we usually say to start having intercourse. is kind of the peak of fertility days. But I wouldn't be too concerned whether your surge is 1 day or 3 days. I think it's more just being able to detect the ovulation event. Now, if you're getting two completely separate surges that are where you have a positive test and then it's negative for a while and then another positive test, then one of those is probably not a real ovulation, and then I would say then the test is not accurate if that's what's happening. If the ovulation tests are not reliable, they would be a good candidate for coming in for blood work and ultrasound monitoring, which is much more accurate, or can be much more accurate, I would say, in those situations where the ovulation test strips are ambiguous. Then it's best to monitor with blood work and ultrasound, which will be more accurate. Let's see here. I'm going to go back here a little bit. There's a question here about when you're doing embryo genetic testing, why do you need to have DNA from the parents? I think that's what it means. Parents. It says parents twice, but I'll talk just a little bit about that. So let's say you have a case where somebody carries a particular genetic condition, let's say like cystic fibrosis, and that's detected usually through some blood work testing that determines that a couple both carries the gene for cystic fibrosis. If that's the case, we basically need to have a genetics lab design what are called probes. And the probes basically are what will be used when we get the embryos to test to see whether the embryos inherited the gene or not. And often they will be able to tell from the probes. They can look at the mutation or the mistake in the mom's chromosome and in the father's chromosome. And sometimes they will also need other family members as well. And so sometimes they will ask for either siblings or parents for their genetic samples as well to help design these probes. And they also look at the markers that link the gene to basically be able to tell where the gene is being inherited from. So sometimes they can get some additional information from siblings and parents, or if they have children that are affected by the disorder, often they will get samples from all of the different family members to help design these probes so that they can more accurately determine whether the genes of an embryo are going to be normal or abnormal, so that we can tell whether that's an embryo that we can use or not. And so, very good question. It's a little bit of a complicated question, but very good question. So we're almost out of time here, but I'm going to try and answer a couple more questions. Another question asks about, what are reasons why eggs may arrest or have fragmentation after fertilization before day 5 of the transfer process. And so we'll talk a little bit about that. And so another thing to kind of talk about is, what are expectations in terms of eggs during an IVF cycle? And I would say usually our goal with IVF is trying to get 10 or 15 eggs in an average IVF cycle. Sometimes we get a lot more than that. Sometimes we get fewer than that. And like we had talked about before, there's no age at which, or there's no FSH cutoff, or there's no AMH cutoff whether it determines somebody can or can't be successful. There's also no number of eggs that says whether somebody will be successful or not successful with IVF. I've had patients who have had one egg retrieved with IVF and have had live-born babies, and so it only takes one egg. That being said, our goal usually is to try and get multiple eggs with IVF, and we try and get usually around 10 to 15. And the reason is that only a small number of the eggs actually will make embryos. And so typically, we'll take with the example of starting with 10 eggs. So in general, if you have 10 eggs, usually 7 of those eggs are mature when you take them out and you look at those eggs under the microscope. Of those, when you go to fertilize them, usually about 70% of the mature eggs will fertilize. So that usually means you have about 5 fertilized eggs. And of those, usually about 40% of those will make it to the blastocyst stage. So not all of the embryos that form, the eggs that fertilize and make an embryo, not all of them make it to day 5 for a transfer. Or sometimes we will even do what's called a day 3 transfer. We'll transfer them a little earlier. So once an embryo forms, essentially the egg and the sperm combined, they each have 23 chromosomes. They form the embryo that then has the 46 chromosomes that are necessary for life. And that's one cell. So once the egg fertilizes, it's still a single cell. It then has to grow and divide. And as it divides, that's called a cleavage. And so it goes from 1 cells to 2 cells. Those 2 cells then divide and becomes 4 cells to 8 cells, and it continues to multiply the cells within the embryo. Sometimes those cleavages occur nice and crisp, and you have equal size cells. Sometimes they can be uneven. Sometimes, essentially, when they start to cleave, you'll see little blebs of what's called the cytoplasm. You kind of think of the cytoplasm as the jelly inside of the cells of the embryo. Sometimes some of that gets kind of spit off, and those are called fragments. And so usually if you see fragments or if you see uneven cells, that's usually not such a good sign. That's usually an embryo that's not doing as well. And so some of those embryos may what's called arrest. They may stop dividing at some point. And so it's not unusual for, to get a group of, let's say, embryos. You may have 5 embryos, but a few of them will stop dividing, let's say, at 6 cells and 8 cells. One may stop at the morula stage. And then hopefully there are a couple that actually make it to the stage that actually can make it to the blastocyst stage for transfer. And so with that, I'd like to we're coming up here on an hour, and I would really like to thank everybody for tuning in today. It's been fantastic to see a lot of my former patients on here. It's been nice to answer questions for those of you that had questions. If anybody has any comments or any other questions, feel free to leave them in the comment section, and we will try and have somebody reach out to you. Really happy to participate in the event, and wishing everybody well in whatever their fertility journey is. With that, thank you and good night.